I'm going to announce today's speaker. We have the pleasure of having Dr. Sahera Dirajlal-Fargo, who is an attending physician in infectious disease at Lurie's Children's Hospital in Chicago. After her residency, she spent a year working as a pediatric AIDS corps physician for the Baylor International Pediatric AIDS Initiative in Malawi. She also trained in infectious disease at Children's National Medicine Center in Washington, D.C. Dr. Fargo is a translational investigator whose research portfolio focused on complications of HIV in children and youth in the US and also sub-Saharan Africa, where a lot of us also are engaged. She is the principal investigator on multiple NIH-funded studies in the US and also Africa to better understand the long-term health outcomes and chronic comorbidities that are associated with HIV in adults and children. And she's the co-director of the Center for Pediatric Global Health at Northwestern University, where she's also an associate professor. She specializes in providing HIV care and treatment to infants, children, and adolescents, both living with and exposed to HIV, as well as the aspects of pediatric infectious disease. So great topic, very important to many of us in the center. Thank you so much for being with us today, and the floor is yours.
Thank you. Thank you for the kind introduction. So I'm going to go ahead and share my slide. Just one second. All right. So thank you again for the introduction. And I'm delighted to be here. The focus of my talk will be on the dual disease burden in youth with perinatally acquired HIV. I have no conflicts to disclose. So for today's talk, I want to briefly kind of bring everyone up to date on the current state of the HIV epidemic. I think everyone in this audience is probably aware, but I want to make sure I do it with the pediatric focus. I want to discuss the possible and studied clinical implications of premature aging in youth with perinatally acquired HIV. And throughout my slides, when you see the acronym PHIV, it refers to youth, young adolescents, and adults living with perinatally acquired HIV. We will touch on briefly the mechanisms to understand aging with HIV, again with a pediatric focus, and then I'll briefly touch on future directions and strategies to mitigate premature aging. So I think we're all aware that overall the burden of HIV still resides in sub-Saharan Africa. And this is a slide from UNAIDS and UNICEF highlighting that the number of children 0 to 14 who are living with HIV, again, still the burden still reside in sub-Saharan Africa and South Africa. So I want to just bring your attention to a couple of numbers that I think are important to set the stage. So it's estimated that there are around 2.5 million children under the age of 14 living with HIV. And the other kind of staggering statistics is that not only do they bear the burden of the virus and every complications that are associated with living with HIV, which we'll touch on during this talk, but I think the other important factor is when we look at the number of children who've actually lost one or both parents to the AIDS epidemic, it's a staggering number, almost 14 million. So I think it's important to keep in mind, and this center and a lot of you here are familiar and do this type of work when we think about kind of the social stigma and the overall burden outside of the virus that are imposed on these kids. So the good news is when we look at new number of infections, they've drastically decreased since the early 2000s and PEPFAR. We've had about a 60% decline in new infection between 2010 and 2014. However, in the last 3 years, we've kind of stagnated, and that's been continuous. And if you go to any pediatric HIV conference, this is what we mostly talk about is what's happened and what can we do. And especially in the last year, we were already stagnating prior to 2025 and how to move forward. So we've come a long way. The progress has stalled a little bit. And similarly, so I've just showed you the slide for kids 0 to 14. The same is true for adolescents 15 to 19. So again, a big drastic decrease in number of new infections, but a stagnation where we're still kind of at 150,000 new infections per year between 2023 and 2024. So where have we come from and how did it start for me? So as was mentioned in the introduction, I spent a year in Malawi as a pediatric HIV doc. And this was really, not to age myself, but in the mid 2000s, right when there wasn't really a scale up in terms of diagnosis and treatment for pediatric HIV in sub-Saharan Africa. And so there were 14 pediatricians in the country. 12 of us were deployed by Baylor. So really, we had a huge job of just education and task shifting. And so initially, we would just round in the pediatric wards as pediatricians and quickly noticed that we had a staggering number of malnourished kids who didn't respond to nutritional supplements and the WHO standard of care for moderate to severe malnutrition. So we started establishing kind of preventative testing and found that a really high number of kids in the malnutrition ward were actually HIV positive. And you can see a couple of the kids here. And so that quickly evolved and we started preventing also providing care to mothers and doing PMTCT work. And you can see here the mothers are lining up. So this was really a time where we were all focused on keeping these kids alive, right? And preventing mother to child transmission. And we've come such a long way where our past goal was to stay alive. There's been, the good news is deaths have decreased for adults and for children. There's an 80% decline in deaths from the peak in the early 2000s. So again, similarly to new infection, when we talk about mortality, we've come such a long way. And for me as a pediatrician, when I see these kids in my clinic, really the goal is to keep them virologically suppressed, to make sure that we start ART early so that we have a good immune recovery and we maintain their CD4 cell count as high as possible. Most of the kids are now on one pill once a day. And a lot of them are long-acting injectables, which has been really a game changer, especially for adolescents with perinatally acquired HIV that have really bad memory of testing really poor palatable medicines. And then my job more and more as a pediatrician is actually to manage comorbidities, which I really didn't think about when I did my pediatric residency, that I would be managing comorbidities in adolescents and young adults. And I'll talk about that a little bit more. So this slide, credit to Stephanie Shah, who's I think is on this call. This is really trying to give you a pictorial description when we think about expected survival for a 4-year-old. So just to orient yourself, the women are on the left, the men are on the right. For women, and then the gray person is the general population. So women who have started ART before 2015, the expected survival for a 40-year-old would be about 35 years of age. And you can see that the expected survival has increased. So women who have started ART after 2015 are gaining a few more years of age, but we're still not quite meeting the life expectancy of women without HIV. And the same can be true for men. So it's been wonderful to see that increased lifespan. However, it's come at a cost. And this graph shows you kind of the top portion is the lifespan of those with and without HIV. And the bottom graph shows you the comorbidity-free years of those with in triangles and without HIV in circles. And you can see in terms of HIV infection, those people living with HIV live 9 to 16 fewer healthy years when compared to those without HIV. So again, that increased lifespan has come at a cost, and we really need to focus on health span. So ensuring that those young adults are living their most productive years of life without comorbidities. So this graph really shows you the hypothetical dynamics of the biological aging process in those without HIV in blue and those with HIV in orange, red, based on studies that have been done mostly in adults living with HIV. So you can see in untreated infection, the process seems to be more accelerated than the one in non-HIV in blue. And with the introduction of ART, you can see that biological aging trajectory seems to be dampened, but does not reverse. And so in this stage, the biological aging is probably either more accentuated or accelerated than the reversion that happens, or than those who are living without HIV. Now, what I want you to keep in mind is aging happens no matter what we do, right? It happens to everyone, but it's also accelerated, and there's evidence of this in those young adolescents and adults who have been born with HIV. And that's an important process, isn't that? Where are they on this graph? Are they more accentuated? Are they more accelerated? And how early does the process begin accelerating? And I want to talk a little bit about what the consequences of that accelerated or accentuated aging is. So I think we're all familiar with HIV-associated comorbidities, and they're highlighted here in this graph. Our group is really focused on cardiometabolic complications, so cardiac and also endocrine, and I'll touch base as well on neurological and mental complications. So the majority of studies, again, that have been done on HIV-associated comorbidities, I've really focused on adults who have horizontally acquired HIV. And so you can see here with this graph that young adults with HIV are also at risk of comorbidities. This is a study that has been done from hospital database from the Massachusetts General Hospital by Virginia Triant. And what they did is they looked at a heart attack, so myocardial infarction rates in those with HIV in blue and those without HIV in green. And what I want to point out is that you can see even those between 18 to 35 years of age, so really quite young, are having a fourfold increased risk of myocardial infarction. And that's huge. And so what I'm interested in is trying to study this in a setting that's mostly endemic to kids with perinatally acquired HIV, and trying to understand the mechanisms so we can mitigate this. So again, back to this map that you all know very well. When we look at studies that have been done in terms of comorbidities in youth with perinatally acquired HIV, you can see there is a true geographical discrepancy in terms of where the prevalence is and where the research is taking place. So these green dots are meant to highlight peer-reviewed publications in the last 5 years. And again, the focus has been A, on adults, and B, for the publications that have actually focused on youth with perinatally acquired HIV, they've been mostly in the global north, so not really where the prevalence is the highest. There's also several challenges in studying this population, is that one, they've started ART at a period of critical immune development, so really before immune maturity, which is why we're seeing actually a lot of adolescents and young adults still having pretty low CD4 cell counts because they never had full immune recovery. They're on ART for much longer than adults, right? An 18-year-old will have ideally and theoretically been on ART for almost 2 decades. They've been exposed to older, more toxic regimen, and we think about the thymidine analogs, so AZT, D4T, drugs that we know can really impact mitochondrial dysfunction and continue to impact the mitochondria much longer after they've been stopped. Fortunately and unfortunately, they don't have true heart outcomes. So in my clinics, I don't really see a high rate of myocardial infarction in 16-year-olds. But that doesn't mean that they don't have the precursors to those myocardial infarction. So unlike the larger ACTG trial, right, trying to test out statins in preventing major adverse cardiac events, it's much harder to figure out what's the outcome of interest and to make sure that's homogeneous throughout the literature. They have differences in traditional risk factors and social determinants of health. So one of them I already highlighted earlier in this talk is that a lot of them have been orphaned by the early AIDS epidemic. And in terms of differences in traditional risk factors, sometimes we have a tendency to compare data from the global north to the global south. And I'll give you an example. Almost 60% of the adolescents that I see either vape or smoke, all sorts of things. our cohort in sub-Saharan Africa, most of them have never smoked. They don't have a history of smoking. They're not current smokers. And so it's really important when we try to measure, especially cardiometabolic disease, that we really keep in mind traditional risk factors and social determinants of health. And then when we do measure cardiometabolic risk, what does that mean? So if I tell a clinician, okay, we have found evidence of cardiometabolic disease in our cohort, how do I put that into context from a clinical standpoint? And how can I help my clinician colleagues on the ground in sub-Saharan Africa put that into context and do something in terms of mitigating long-term complication? So I hope I've set the stage to really kind of dive into the clinical implications of premature aging in youth with perinatally acquired HIV. So I want to highlight our work and our team. I've been fortunate to work with an incredible team at the Joint Clinical Research Center in Kampala and Makerere University. I had tremendous mentors here in the US who have guided me, and I've had funding from my Mentored Care Award, where I really built up this cohort of youth with and without HIV in Uganda, to this present day with some excellent colleagues who are on the call today. So like I mentioned, my group is really interested in mostly studying cardiometabolic complications, and it's important to understand the precursors that eventually lead to comorbidities. So what do I mean by precursors? So insulin resistance or prediabetes is an important one. Dyslipidemia, measuring obesity, and in the US we think about visceral obesity, so having fat really in the trunk portion is known to be a higher risk for cardiovascular disease. And then where the fat is located and what type of fat is also really important to understand future risk of heart disease. So this is kind of a snapshot of our cohort. Most of the kids currently are around 16 years of age. You can see that they're well balanced by sex. We started enrolling them when they were about 10 years of age. Most of them have gone through puberty, or I should say half of them have. And I listed here socioeconomic variables that are important. So what I want to point out is about a quarter of them live in economic insecurity. And what I mean by that is living on about less than $2 per day, which is set by the World Bank as living under extreme poverty. When you look in terms of education, it's also important to notice that, and what we found is that oftentimes education doesn't match with age, so they can be a little bit behind with school. By design, most of the participants were virally suppressed, so less than 50 copies per ml. You can see at 16 years of age, most of them have been on ART for 13 years. And then lastly, all of them are on dolutegravir-based regimen, or TLD, which is the regimen recommended by the WHO that were adopted by Uganda around 2022. And so kind of the first thing we wanted to look at is body composition. So we took the kids with perinatally acquired HIV and compared them to the seronegative control. And by history, none of them had co-infection, so no active malaria, no active TB, etc. And all of the HIV participants were on stable ART for at least 6 months. So we did kind of a simple study design. We put them through a DEXA scan to look at their body composition. We also measured fasting glucose and insulin to measure their insulin resistance, did lipid panels, and then look at markers of systemic inflammation and gut markers that have both been associated with these specific metabolic comorbidities in adults living with HIV. So what we found, to our surprise, so in blue are those without HIV, in pink are people living with HIV or perinatally acquired HIV. And you can see we looked at body composition, we looked at total body fat, total trunk fat, we looked at extremity, we looked at the ratio, and we really didn't find any differences. Again, the cohort is not huge. What's interesting is this is really different from what we have found in US-based study or the FAAP study, the pediatric HIV cohort study, where body composition was actually in line with cardiovascular disease and they had higher trunk fat. So in a sub-Saharan African population that is most urban, in youth who are virally suppressed and balanced by sex, we really didn't find any differences in body composition. So what we did next is we looked at differences by sex, and not surprisingly, you can see that female are more likely to have increase in total body fat, increase in trunk fat, increase in extremity fat. And so we kind of wanted to see if there was a phenotype that was concerning for cardiometabolic risk factor. And we did cluster analysis, and I want you to focus on what I will talk about is mainly this cluster on the right. So what we found in this cluster on the right in blue, or cluster 1, is we found that these kids had higher total body fat and higher trunk fat. They were more likely to be female, as I showed you in the box plots earlier. What's also interesting is that these girls were also more likely to be inflamed. So they had higher sensitivity CRP, they had higher marker of monocyte activation, and they had also higher marker of translocation, both fungal and bacterial, which I'll touch on in a little bit. And so there wasn't a statistically significant difference in terms of HIV status, but these girls were more likely, there was a higher likelihood of them being HIV positive. And so we talk about body composition. Now we were interested in lipids, right? I talked about insulin resistance, body composition, lipids. So what's interesting is that when you get your cholesterol checked at your doctor, so the traditional lipid panel, you're getting your total cholesterol, your HDL, your LDLs, but we're not really diving into the type of lipids that we see. And so we were interested in trying to find, okay, we dove in a little bit about body composition. Let's now dive into lipids. And this is a graph kind of highlighting how lipids can be categorized and classified. And so if I go in and dive in a little bit further, when we think about lipids, so lipids, have a, back to chemistry, have a hydrophilic head and a hydrophobic tail. That hydrophilic head really tells us the lipid class. So what kind of group do they belong to? Are they fatty acids? Are they glycolipids, ceramides, et cetera, et cetera? And certain lipid classes have been associated with higher risk of cardiovascular disease. So that's the hydrophilic head. When you look at the hydrophobic tail, so the legs of the lipids, you can determine the lipid species. So our group was really interested in looking at the lipid classes and the lipid species. And the lipid species really tells you, are they saturated, meaning they have no double bonds? Are they unsaturated, meaning they have more than one double bonds? And we know that PUFAs, or polyunsaturated fatty acids, are really kind of the species that we're interested in when we talk about cardiovascular disease. So what was interested is that when you look at traditional lipid panels, so cholesterol, HDL, LDL, triglycerides, we don't really see a difference by HIV status. But when we look at the composition of the lipidome, so we did lipidomics assay, again, looking at that lipid class, that lipid species, we see a very distinct lipid signature. So what you see here, sorry, the colors are a little bit swapped from earlier, but in red is those living with HIV, in blue are those seronegative kids. What you see is that we've definitely found a certain lipidomic signature that's unique in those kids living with HIV. They have a higher concentration of saturated fatty acids, and they have species, specifically ceramides, cholesterol esters, and fatty acids that are more likely to be saturated, which are species that are known to be associated with cardiovascular disease, and really large cohorts that have been done in adults without HIV. So again, just a recap, body composition is different, may not be just by HIV serostatus. Traditional lipids may not be different, but when you dive down to lipid classes and lipid species, we're seeing a distinct lipidomic signature. So I've shown you kind of the precursors of cardiovascular disease. Again, what I've mentioned earlier is that we can't measure major adverse cardiovascular events because fortunately they're not having MIs and strokes, but there are different surrogate markers that we have to measure cardiovascular disease. So we can measure cardiomyopathy, we can measure subclinical vascular disease, we can measure endothelial dysfunction, and we can measure fibrosis and inflammation. And again, all of those precursors have been noted to be associated with heart disease in really large cohort in adults with and without HIV. And this is the modalities that we use in order to measure those cardiovascular disease surrogate markers that are non-invasive, and some of them are more easily done in lower income settings than others. So for the purpose of this talk, I'm going to focus on carotid ultrasound, which was available at the time that I started working at the JCRC. And fortunately, the pediatricians were trained in how to measure carotid ultrasound. So we were interested first to look at subclinical vascular disease. And what we looked at is the intima media thickness in the carotid arteries. So a probe is placed on the neck, on the carotids of these kids. And this is our patient 0, actually, that we measured this on. And what I'm showing you here in this table are data that have been done comparing those with and without HIV in several settings, looking at carotid ultrasounds. So the first thing I want you to note is the majority of studies, again, have been done in the global north, comparing the two population. The other thing I want you to note is when you look at differences, they're significant, but they're really quite small, less than a millimeter. So I get asked this question all the time: is this really significant and clinically meaningful? So what's interesting is that when you look at really large studies that have been done, again, in adults without HIV, you can see that even a 0.1 millimeter difference has been associated with a higher risk of myocardial infarction and stroke. So at the time of this study in Uganda, the median age was 12 years old. And you can see that even at 12 years of age, in virally suppressed kids, they have evidence of subclinical vascular disease that has been known to be associated with future risk of heart events, of cardiac events, sorry. So the next thing we measured is endothelial dysfunction. So endothelial dysfunction, again, is known to precede heart disease. This was measured by a machine called EndoPAT, and we measured the reactive hyperemic index. So what we do is we put a little finger probe, we have a blood pressure cuff that we inflate, and we measure the pre and post hyperemic index. And that tells you how responsive are your small micro vessels to stress and being compressed. And the lower the reactive hyperemic index, right, the more likely you are to have endothelial dysfunction. And so what I want to show you here is that when we looked, this study was done in Cleveland. This one is from the Cape Town cohort, the CTAC cohort in Cape Town, South Africa. What we found is that a low reactive hyperemic index, and even lower in youth with perinatally acquired HIV compared to age and sex matched youth with horizontally acquired HIV. Again, highlighting the fact that this population is distinct and might have higher risk of future heart disease. So if you are an internal medicine or family practitioner doc, and you see adults in your clinic, you have different risk scores that you can use to determine future risk of heart disease. We don't really have that in pediatrics. Most risk scores have really been established for adults over the age of 40. So the PDAY score, or the pathobiological determination of atherosclerosis in youth, PDAY, has really been established in order to develop a score for the pediatric population to ascertain future risk of atherosclerosis. So the PDAY score was developed using data from the PDAY study, in which subclinical arteries atherosclerosis was determined pre-mortem from kids 15 to 34 years of age who have died from external causes. And what the score uses, so points are acquired, same as the ACC or the AHA pool cohort equation. You get points for non-HDL cholesterol, age, hypertension, male sex, obesity, HDL cholesterol, and smoking. There was a really large study called the CARDIA study, looking at youth without HIV between the ages of 18 and 30 years of age. And what they found is that their PDAY score was around 1.35. And any score over 1 was associated with an increased risk of atherosclerosis progression 25 years later. So they followed this cohort for about 30 years, and they found that anyone with a score greater than 1 was associated with a higher risk of myocardial infarction or ASCVD 25 years later. And what's interesting is that PDA score was measured in different larger cohorts. So again, in that Cape Town cohort, and we also measured it in FAAP, so the pediatric HIV/AIDS cohort study in the US. And we found that around 30 to 48% of kids with PHIV had a coronary PDA risk score equal to or greater than 1. Again, I want to highlight, and I'm repeating myself, that these kids, despite being really young, are showing evidence of comorbidity precursors that are known to be associated with the full-blown comorbidity later in life. So what's interesting is that these complications really don't live in a vacuum. Again, data from the CTAC cohort in Cape Town. And what you're finding here is that youth with PHIV are at risk of systemic impairments. So the graph on the left is showing you PHIV kids. The one on the right is age and sex-matched seronegative youth. And what they looked at is the risk of having more than one system involved. So they did pulmonary function test, they did echoes and cardiac ultrasound, they measured kidney function, they also did the equivalent of like an NIH toolbox for mental health and neurocognitive impairment. And what they found is that the two systems that were more likely to be involved at the same time in youth with HIV are cardiac complications and neurocognitive impairment. So like I said, our group was initially really focused on cardiometabolic complication, and we thought, okay, so let's really look at neurocognitive impairment and neurocognitive performance. And hopefully in these pictures, you'll recognize some of your colleagues at NSP Columbia. So Dr. Robbins was initially funded by an R21 by the Fogarty Institute. And what we did is we leveraged that initial cohort from my K award in order to try to see if we can scale up NeuroScreen and translate it and adapt it to the Ugandan setting in order to measure neurocognitive impairment in these kids. We're now funded for a bigger grant called Enrich Plus, and what we're doing is taking that cohort and expanding it and trying to measure neurocognitive impairment, and also environmental factors, which I'll talk about, social stigma, social determinants of health, air pollution, that can contribute to the immune dysfunction and neurocognitive impairment. So we're measuring this, like I said, in a larger cohort of youth with perinatally acquired HIV, youth with horizontally acquired HIV, and seronegative participants. And so we have some preliminary data. This is Caroline Carlson. She's a third-year medical student here at Northwestern who's working with me and looked at our initial measures of NeuroScreen in youth with and without HIV. And so what we're finding here, again, in green are youth without HIV, in dark blue are youth with perinatally acquired HIV, and you'll appreciate that in almost all domains, youth with PHIV are performing poorly compared to seronegative youth in terms of that NeuroScreen and neurocognitive domain. So we also wanted to see if evidence of neurocognitive impairment remained after we adjusted for demographic and some socioeconomic and social determinants of health. So we adjusted for age, sex, BMI, education, food and energy insecurity, and access to clean water. And you can see that even after adjusting for those factors, youth with PHIV are still performing poorly compared to seronegative youth in almost all domain and the total global Z-score. So this is Angel Nenteza. She's was a master's student who has worked with us for several years and is interested in mental health. So we also administered the PHQ-9 to those adolescents. And what you'll see here is that she found a significantly higher proportion of lifetime suicide attempts, which really was surprising to me because my radar was so focused on that heart health that this was not at all something that I had thought about. So higher attempted suicide in adolescents with perinatally acquired HIV compared to HIV negative peers. So you can see 14% versus 0% respectively, which was striking. This is considerably higher than what's been reported in sub-Saharan Africa, and especially among Ugandan adolescents from what we could find in the literature, but consistent with really what they reported. So ideation, planning, and attempt. And so we're hoping to dive this into a little bit more with our Enrich Plus study. So just to recap, I've told you a little bit about kind of the epidemic and how it's changed and how far we've come and how our focus has changed. I've told you about evidence of cardiovascular comorbidities or precursor to those comorbidities. I've also briefly touched on how this is not just living in silo, and kids with perinatally acquired HIV are probably having other comorbidities and may have kind of the syndemic of comorbidities. What I want to touch on for this next part of the talk is kind of thinking about what are some mechanisms that may be associated with premature aging and may be causing some of these precursors. So geroscience is the concept model of aging with HIV. It's also very funny to me to as a pediatrician to talk to you about geroscience and aging, but geroscience really offers a framework for understanding and addressing how accelerated aging may actually be working for youth with perinatally acquired HIV. But instead of just targeting one specific mechanism, we're really kind of focusing on all mechanisms of aging. And it recognizes that HIV infection can accelerate biological aging and lead to age-increased comorbidities. So what you see on this graph here, on the blue are the primary hallmarks of aging. In orange are antagonistic factors, and in red are integrative hallmarks. So blue, the primary hallmarks of aging you can see here, like telomere attrition, epigenetic alterations, which I'll talk about, are really kind of the initial damage affecting the genome and the telomeres that can progressively accumulate over time. In orange, the antagonistic factor really reflects how the body responds to damage. So it plays a more nuanced role, like mitochondrial dysfunction, et cetera. Nutrient sensing, deregulated nutrient sensing can sometimes be actually beneficial early in youth who may be a little bit stunted, but long-term plays a role in metabolic complication. And then what happens in the last piece, which is the integrative hallmarks, is these arise when really the damage inflicted can no longer be compensated and really results in stem cell exhaustion, chronic inflammation, dysbiosis. And what's interesting with these kind of integrative hallmarks is a lot of you will recognize this is exactly what happens with chronic HIV, regardless of viral suppression and longstanding ART. So really kind of helps us think about a framework to further investigate the mechanisms of comorbidities in this population. So what is known? It's been well associated that inflammation is associated with complications of aging in adults living with HIV. I've just listed a couple of markers here that are associated with lung disease, diabetes, cardiovascular disease, neurocognitive impairment, frailty, and bone dysfunction or sarcopenia or frailty. Again, these have been well established and also established to be associated with not only comorbidities, but also overall mortality. So what we don't know is whether inflammation persists in youth with HIV despite viral suppression, whether that inflammation is associated with complication. Is this process homogeneous for all PHIV worldwide, right? Global North versus Global South. And again, my study with Ruben really focuses on things outside of HIV that can contribute to inflammation. And that's when setting becomes important. And then what other mechanisms of aging are we seeing in youth with HIV? And I'll briefly touch on that. So first question, does inflammation persist despite viral suppression? So again, we took that cohort that was virally suppressed. We have been following it for about 7 years now. And what we wanted to measure is really just measuring their inflammatory markers, both cellular and in the plasma, after being 2 years on ART and documented viral suppression. So what we found is markers of gut integrity, IFAB, remained, remained increased after 2 years compared to seronegative youth. BDG, which is a marker of fungal translocation, also remained increased. Markers of monocyte activation, so soluble CD14, and also patrolling monocytes. So we looked at plasma markers, but we also had PBMCs and measured monocyte activation in the PBMCs, also remained increased compared, and again, this is all changed compared to seronegative youth. And then T cell activation also remained. And that's not surprising. That's a well-known fact of HIV. So let's just take that soluble CD14. That still remains increased after 2 years compared to seronegative youth. We know that soluble CD14 is a powerful predictor of morbidity and mortality in adults living with HIV. It's been associated with poor prognosis. Despite viral suppression and dolutegravir, these levels remained elevated. And in our cohort, we have found that soluble CD14 was independently associated with subclinical vascular disease, endothelial dysfunction, and metabolic comorbidities. So again, answering, does inflammation persist? Yes. Does it seem to be associated with comorbidities? It appears to be so, similarly to adults. So again, I want to touch base on the setting. So we had PBMCs that were stored from those Ugandan kids living with HIV who were virally suppressed and seronegative youth. We also collaborated with the cohort in the US. They also were virally suppressed and had PBMCs that were stored and plasma. And what we did is we ran a panel of chemokine, inflammatory, and vascular markers in youth with and without HIV in Uganda and the US. And we're interested in looking at the differences. And so what these volcano plots are showing you is that higher levels in this box compared to US kids with HIV, I'm sorry. And then lower levels in Ugandan kids. So what you can see is that when you compare Ugandan kids to US kids, we're definitely finding differences. Again, not everything was perfect. That was not the goal of the study. They were matched by age and sex, and they were all virally suppressed. So what we wanted to highlight is that kids with HIV are different, but you can also see in this volcano plot when we compared Ugandan and US negative kids, there's also differences. And this really highlights that the environment, social determinants of health, things outside HIV, or maybe even HIV clad, really makes a difference when we're talking about the profile for inflammation and immune activation. So this is what this grant and this next study is really focused on. We're looking at the role of trained immunity and mitochondrial dysfunction in children and adolescents with perinatally acquired HIV, mostly focused in Uganda, but hoping to continue our comparison with stored sample in the US. So we're looking at trained immunity. It's really a training process that involves epigenetic reprogramming of cells and alteration in gene expression. And these changes alters how a cell responds to future challenges. So what we're hypothesizing is that kids in Uganda and their immune cells have really been primed by what they've seen historically, both in terms of immunization, infections, parasites, viruses, and that has really caused an altered responsiveness and reprogramming in terms of how immune cells, specifically natural killer cells and monocytes, are responding. So I don't want to spend too much time. We really love these types of analyses. I've shown you so many cluster analyses, but what I want to highlight is that youth with PHIV have gene expression signatures of trained immunity, kind of really their cells being primed for future events. So if you look here in this cluster analysis to this box, you can see that the majority of these kids are HIV positive here in dark blue. and have this pattern of gene expression where they're more likely to have cells that are immune trained and have epigenetic regulation. Again, almost kind of the precursors to that chronic inflammation and being primed to respond and eventually downstream having comorbidities. The next thing we looked at, so inflammation and chronic immune activation. And if you remember in that primary hallmark geroscience framework, there's also gut translocation and gut integrity barrier dysfunction. So it's important to remember that the gut is really kind of a sentinel site for HIV and where HIV resides at the beginning of the infection. And what we were interested in is measuring gut barrier dysfunction and whether that persists, fuels inflammation, and is associated with complication. And as I showed you in a couple slides earlier, is FAAP, which is a marker of gut integrity, remains elevated compared to seronegative youth. Not only does it remain elevated, but we have found that it's independently associated with a lot of other things that we've measured that I've talked about earlier. So it was independently associated with trunk fat, with HOMA-IR or prediabetes and insulin resistance, with carotid IMT or subclinical vascular disease, with the altered lipidome that I've shown you, and also with some of the neuroscreen markers, so neurocognitive impairment. So lastly, I want to just briefly touch on evidence of advanced biological age through epigenetics. So you've probably heard a lot about epigenetic modification and biological clock. I think it's a really hot topic lately. So you'll remember that epigenetic transformation is really kind of changes that happen to the genome. And in this case, the most common change that has been investigated is methylation on the genome. So intrinsic and extrinsic epigenetic changes. And from those methylation and epigenetic changes, you can measure kind of an epigenetic clock or a biological clock versus a chronological clock, which is our natural age. So there's preliminary data, and this is a study by Stephanie Shao out of FACS, highlighting the fact that when you compare youth with perinatally acquired HIV to youth who are HIV exposed but uninfected, there also seems to be evidence that chronological age may be advanced and that they have increase in epigenetic age compared to those who are HIV exposed and uninfected. So they may be experiencing biological aging at a faster pace than the chronological aging. So just a quick recap, we've talked about kind of the epidemic, we've talked about comorbidities, not just cardiovascular, but also others. We've briefly touched on possible mechanisms that are associated with premature aging, including inflammation, immune activation, trained immunity, gut barrier dysfunction, and briefly touched on the role of epigenetic aging. So after all of this, what can we do as clinicians? What are some future interventions and strategies and evidence that exist out there to mitigate aging? So I think it's important that although we have an accumulation of evidence that points to the fact that both clinical and behavioral risk factors for, let's talk about cardiovascular disease here in this case, happen in early life, and that evidence suggests that early risk is an important determinant of future events, such as heart attacks and strokes. There is really very few interventional trials and prevention that have happened in kids or in adults under the age of 40, right? The majority of prevention trials for cardiovascular disease have been done in adults over the age of 40. And really building an evidence base for cardiovascular disease prevention needs to happen really early on and will require the engagement of young adults who, more and more are becoming disconnected from healthcare system and may not prioritize their long-term health. It's really hard to convince an 18-year-old that what you do today will probably, dampen your risk of heart attacks 20 years from now. But I think it's important to recognize kind of all of the risk factors, not only biological, but community, interpersonal, and individual, that lead to increased risk of CVD further down the line. So we talked about things that are involved in the geroscience model. It's important to think about the easy stuff that you can do in terms of geoprotectors, right? And those are the boring stuff that we tell our patients all the time or that we tell ourselves. So, eating well, a nutritionist and balanced diet, regular exercise, making sure you're mentally stimulated and have good mental health habits, and then social collections. So let's look at some of these factors in the cohort that I introduced you to. So when we talk about physical activity and nutrition, we've adapted a dietary questionnaire from the World Food Program to measure dietary diversity. It's really hard overall to capture dietary questionnaires, even here in the US, but it's even harder to do in a lower and middle income setting. So we adapted these questionnaires to really try to measure and get a capture of dietary diversity, which gives us an idea of like how balanced their diets are and how nutritious and their macronutrients, because we weren't so concerned about the total calorie, just more so how are they eating. And you can see that although the differences are not large, those with perinatally acquired HIV, again, from the same capital peri-urban setting, have a slightly lower dietary diversity score. They eat a lot less fresh produce, a lot less meat, and just a lot more starch. Next thing we did is we just asked them about physical activity for the last week. And what you can see here is actually, surprisingly, those with HIV have a lot more moderate activity than those without HIV. And it's hard to kind of put into framework what is 1,500 minutes. So I can't quite convince youth here in the US to do 2 to 3 hours of moderate activity. On average, youth with perinatally acquired HIV in Kampala do 2 to 3 hours of moderate activity almost every day. So they have a really tremendous amount of physical activity. So we were like, okay, well, that's not something we can actually, change. They're actually doing quite well. But dietary might be something that we want to address in the future when it comes to intervention. So again, I've talked to you about comparing, US to Uganda. We were interested in looking at physical activity in the US. So these are data from the pediatric HIV cohort study, where we looked at mean physical activity after adjusting for several factors, such as where in the US they lived, the time of the year, age, sex, ART. And what you can see here, so the purple dots are those with perinatally acquired HIV. The green triangles are HIV exposed but uninfected youth. And what you can see is around 9 years of age, 9 to 10 years of age, there's really a split. And those with perinatally acquired HIV are really exercising a lot less once they start hitting pre-puberty, puberty, compared to those who are HIV unexposed. So again, this is a nice reminder as a clinician to really try to take stock of how much PE do they have at school, how much exercise they're getting per day. Again, this doesn't live in a vacuum, right? Because I have teenagers who live in neighborhoods where they can't go for walks, there's no parks, etc. But this is an important question to ask when they come to our clinic to try to ascertain how much physical activity and what in their environment can be done to promote more physical activity, especially around 10 to 11 years of age. So we talked about nutrition and physical activity. What about adverse childhood events and just adversity in general? So this is Sarah Al-Johani. She's a resident in Ottawa and became quite interested in the ACE questionnaire that we asked as part of our pilot study, pre-Enrich Plus. And what she found, and really not surprisingly, is that there was a cluster of kids with higher adverse childhood events that were more likely to have HIV, so about 70% of them, more likely to have monocyte and T-cell activation. And of those kids in that cluster were also more likely to have cardiovascular complications. So they had higher blood pressure and higher arterial stiffness over a 2-year period. So you may say, okay, this isn't all that surprising. There's clear evidence in the US and worldwide from cohorts in adults without HIV that adverse childhood events in our childhood really increases the risk long-term of heart attacks. But what's interesting here is the mean age was 16 years of age. So even adversity that are happening 8 years ago are already predisposing them to being at higher risk of having heart disease later down the line. So again, what can we do? What interventions exist that are pharmaceutical? You're all probably familiar with the REPRIEVE trial. This was an RCT looking at major cardiac events in those who were randomized either to pivitastatin, so statin 4 milligram versus placebo. It occurred worldwide in over 7,000 adults. The primary outcome again was major cardiovascular events. The median age was 50. I think 90% of them were virally suppressed, and the trial was stopped after a median of a 5-year follow-up, where you can see that there was clearly lower cardiovascular adverse events in those on statins versus those on placebo. This was really a game changer in terms of guidelines. These guidelines came out 2 years ago, almost exactly 2 years ago, that recommended statins for people with HIV who were at low to moderate risk based on those cohort equations of future ASCVD, so future atherosclerosis event. What's interesting is that these guidelines, the inclusion age is 40 to 75 years of age. So, and what it states is that there's really no evidence to recommend anything under 40. So what about statins for youth with PHIV? I have several PHIV males who are in their 30s, who have prediabetes, who have evidence already of high cholesterol, who have high blood pressure, who of course probably would benefit from statins. So those are really less kind of complicated to deal with from a clinical standpoint, but what about 18-year-olds and 20-year-olds? And I think, I'm not advocating for an RCT being done, but I really do think we need evidence for youth and young adults who are now aging with perinatally acquired HIV. So let's go back to those geroprotectors, right? Like nutrition is targeting something specific, so is physical activity. But what if we went back to our geroscience model framework and think about interventions that could really target more than one mechanistic pathway and just the overall biology of advanced aging in general? So I want to touch on a couple interventions that have been presented in the last year. The first one being GLP-1. So I think you've probably heard a lot about Ozempic and semaglutides, and everybody believes they should be in the water. But these were data that was presented by Michael Corley last year at CROI. This was from an RCT in adults living with HIV. The primary outcome was really looking at lipohypertrophy. This was not a primary outcome, but they had PBMCs and were interested in looking at epigenetic aging. And what you can see is that semaglutides here may have dampened that accelerated or accentuated aging after just a few weeks of being on semaglutide. So more to come, stay tuned. But semaglutide also has evidence of not only the cardiometabolic benefits, may be questionable neurocognitive benefit, and this highlights that this may also have some biological aging benefits. Next, this was brought to my attention again by Stephanie, who's on this call. So taurine is a supplement that's in Red Bull, and this was a study that was done by Singh et al., where they looked at the amount of the semi-essential amino acid taurine in different animal models. And what they found is that decrease in taurine was really associated with a lot of markers of geroscience that we think about that are highlighted here. And supplementation in taurine in different funny animal models, so yeast, worm, and mouse, was associated with really a slowing of those epigenetic, of those aging hallmarks. And so loss of taurine in humans may be associated with poor health and some aging-related disease. So I'm really looking forward to see where that field goes and future evidence to see what taurine that I'm not advocating again to drink Red Bull, but very interesting. And then last and not least, metformin has been studied extensively, not only for its metabolic benefit, but also kind of mitochondrial and immune recovery benefits. So I've seen in literature a couple of RCTs trying to focus on the geroprotective effects of metformin. So more to come, stay tuned. So lastly, in terms of future directions, I hopefully have highlighted the need to expand research on comorbidities in adolescent and young adults with perinatally acquired HIV, again, really focusing on the areas where this is the most prevalent, which is becoming harder and harder to do. We really need to kind of investigate immune dysfunction and gut barrier dysfunction more in youth with perinatally acquired HIV, as those may be really key mechanisms of those aging comorbidities. We've done a tremendous job, and I've showed you evidence of that in terms of increasing lifespan. We really need to focus on health span, and then the need to focus on developing screening, diagnostic, and therapeutics. So all of these studies are great, and I've absolutely loved doing the science, but what I'm realizing is that we're really not screening, especially in LMIC. So if you're not looking, right, you don't really know that these kids have elevated lipids and evidence of subclinical vascular disease. And lastly, I love this picture. This is a mom at the JCRC who herself was born with HIV, and her child who is exposed but uninfected. And this is really this patient population that my heart goes towards. I've been working with them for over 2 decades now, and we've had tremendous success in keeping them healthy and alive. And I really hope that we can continue to do right by them, especially in the current funding structure, in ensuring that they can have really healthy, productive, and aging well. So I focused on the state of the epidemic and kind of brought you up to speed in terms of where we are with pediatric HIV. I've touched on the clinical implications of premature aging and the comorbidities that has been investigated by myself and other groups in LMICs in the global north. We've touched on several mechanisms and how geoscience as a model can really help us think about these complications, and then hopefully some future directions and strategies to mitigate premature aging. So lastly, it truly takes a village. I'm really grateful to everybody that I work with in my group, both trainees, our statistician, that have made this work possible. I've highlighted the team at the JCRC, without whom this work could not have happened. All of our patients and participants and families who entrust us. And then everybody here, I want to highlight the group at Columbia, NISP, Ruben, Courtney, Chris, and everybody with whom we've had a really fun time in trying to get this off the ground, and finally happened this year. And then Stephanie Shao from Rutgers, and want to thank her for some of her slide and genius for sharing those with me. And then again, the support of all of our funders from NIH, the FAAP study, and the Global Health Institute here at Northwestern. So I'll end it there.